Hello, my name is Lindsey Ross. I'm an assistant professor in the Department of Neurosurgery at Cedars-Sinai Medical Center. Today, I'll be talking to you about pursuing equity in acute stroke management. This is a large metropolitan single center mixed method study. The agenda today includes background about stroke inequities in the literature, the methods for my study, some preliminary data, and the future directions. So the literature review shows disparities across the continuum of healthcare delivery. Stroke is the fifth leading cause of death in the United States, and the prevalence of stroke for white patients is 2.3%, where it's 4% in Blacks and 2.6% in Hispanics. Black patients also have increased recurrent stroke rates and higher rates of readmission. Mexican Americans have a higher incidence of intracranial hemorrhages and have higher risks of recurrent stroke rate. That's 1.57 compared to whites. And astonishingly, studies have found that Black patients between the ages of 45 and 54 years old, so this is the younger generation, actually have rates of stroke 3 times greater than their white counterparts. And when it comes to equity in receiving care at hospitals, we know that emergency room wait times prior to stroke team assessment are longer for Black patients and Hispanic patients. And then when we use the clot buster tools, such as mechanical thrombectomy and intravenous thrombolytics, these are lower in use for Black patients and Hispanic patients when compared to white patients. Now, of course, there are important risk factors to include in the analysis of these disparities, and they include hypertension, high cholesterol, diabetes, obesity, tobacco, to name a few. And these are more common in our African American patients, but there are also educational gaps in awareness of stroke symptoms and signs, the influence of risk factors on the incidence of stroke, and when to seek urgent medical care for worrisome symptoms. Additionally, the influence of knowledge, attitudes, beliefs, including mistrust of the healthcare system and the medications that are prescribed, the lack of medical workforce diversity, and then, of course, language barriers. This adds extra layer to stroke outcome inequities and make it even harder to study. And so for the aim 1 of my study is really to assess the disparities in patient outcomes for elderly stroke patients with respect to race and ethnicity. And my second aim is to explicate how patients end up experiencing poor outcomes by describing phenomenology surrounding stroke management. However, today I'm going to talk to you really about aim 1, and I'm actually going to talk to you more about the disparities in patient outcomes with respect to primary language. The data sources I used are electronic medical record, as well as the American Heart Association's Get With the Guidelines Stroke database. And this is a hospital-based quality improvement initiative created by the American Heart Association and the American Stroke Association. And it really is to promote the use of adherence to treatment guidelines. And there are about 2,000 or more than 2,000 hospitals that participate in this database. So we have about a little over 5,000 patients, and the years span 2015 to 2020. This is a process map that shows the patients that come through the emergency room and how they're triaged through the ED and the ED determines whether they have symptoms enough to be called a cold brain. The stroke team arrives and they determine if they need a clot buster, and if so, what type. So the primary outcomes we see here are the door to team arrival, which the benchmark for time is 15 minutes here. The door to needle time, which is the time patients come into when they get the intravenous thrombolytic, 60 minutes. And then the door to puncture time, which is the time in which patients come in and then must go to their intervention up in the angiogram suite, which takes which our benchmark is 75 minutes. So here we could see that 75% of the stroke patients that presented in that 5 years were ischemic strokes, and those are the strokes that are amenable to our clot buster interventions. Here, when we look by primary language, we can see that 20% of the patients do not speak English as their primary language, as designated by the registrar when they arrive. And we can see the next most common language is Spanish, followed by Russian, Korean, and Farsi. When you look at the mean length of stay by language, which is unadjusted, you can see that a statistically significant difference amongst the length of stay, with the Spanish-speaking patients having the longest length of stay. And then when you look at the mortality over 30 days, of course, this is unadjusted, you can see again here that there is differences between patients who speak English and do not speak English. And then there's also some vast differences with particular languages, and in this patient population, it's Korean. When you look at the modified ranking score by limited English proficiency, the modified ranking score really is a functionality scoring system that we use specifically at discharge and thereafter to determine the amount of disability. 0 means no symptoms, all the way up to 6 being expired. So you can see here that patients that have limited English proficiency have a higher degree of disability. So when you look at the NIHSS stroke scale, which is a scale that we use to determine the functional status and the stroke severeness for patients when they arrive at the hospital. In our data, when we look at this plus the modified Rankin scale by language, again unadjusted, we see that there's statistically significant differences amongst language, specifically with worse stroke scales and modified Rankin scales for our Korean patients and our Spanish-speaking patients. So here, when we look at the process map again, and we try to take a deeper dive into what is the language concordant care at the institution, we see that there's various options for interpretation, including digital interpretation and professional in-person interpretation, telephone interpretation, and the use of our certified local multilingual staff. And then after using them through the emergency room and the stroke team, then we go along the same process of care. Through our discussions about the language concordant care, we had discussions with our primary stakeholders, including hospital administration, emergency room staff, interpreter services, and stroke team, as well as our secondary stakeholders, including registration, our payers, our multilingual staff, and our ARIER staff, and created an intervention based on the data that we obtained. And the really objective of this intervention, which was a professional medical interpreter in the emergency room from 9 to 5 on the weekdays, was to improve the patient experience and then thereby clinical outcomes for limited English proficiency patients to hopefully reduce delays and the outliers in language concordant care, and then obviously to analyze the perceptions of language concordant care. Our future work includes using all those quantitative analysis and performing multivariable regression analysis, which really will take into account other risk factors like the presence of hypertension, diabetes, their age, and smoking status, and determining if there's still statistical significant differences amongst different languages. And then our qualitative study will continue to include the semi-structured interview with various ethnicities to determine their perceptions of stroke care, and then complete the analysis for the test of change. Here's some tidbits of the qualitative feedback with quotes from patients that stated the richness of communication with the inpatient professional medical interpreter, and then some of our staff with the assistance of professional medical interpretation to improve quality care for the patients. And I would like to say thank you to my core team here from my institution for all of their hard work, and then additionally for all of my supporters. Please leave questions below, and I look forward to hearing from you.